Posterior cervical facet cages placed through a minimally invasive approach. 44-year-old gentleman with 3-level ACDF with evidence of foraminal narrowing and hardware loosening seen on X-ray. MRI confirming foraminal narrowing at the cephalad at 2 levels and confirmed with diagnostic injections, along with a CT scan showing defluence of subsidence at the proximal 2 levels, along with evidence of pseudoarthrosis at the distal level, seen on axial and coronal CT. Taken to the operating room, placed in the prone position with shoulders taped, iliac crest area identified, and orthogonal fluoroscopy in line with the neck. The head is supported with the foam cushion and is free floating with a towel covering the head and will be prepared in that manner. Iliac crest site and posterior neck wound are prepped and draped using strips of I-band to avoid inadvertent penetration of the I-band, and the lateral borders of the facet joints are marked. The bed controlled is draped separately and incorporated into the surgical field in order to allow for rotation of the bed. AP fluoroscopy is used to identify the medial and lateral borders of the facet joints, and skin markings are used in order to guide incisions onto the facet joints. AP fluoroscopy is used to identify position of the access chisel within the lateral third of the facet joint and to ensure medial clear space on AP and on FOSS views. Lateral fluoroscopy is used to ensure that the tip of the access chisel is not beyond the pedicle margin. Once access chisel position is confirmed, the trephine is used to decorticate the joint over the access chisel. Next, the working cannula is placed over the access chisel and then gently impacted in place and checked on fluoroscopy. Fluoroscopy is used to ensure that the bevel of the access chisel is flush with the posterior margin of the facet joint and it is not beyond the anterior extent of the facet joint. The joint is then decorticated internally using a series of rasps or an internal decorticator, and this is checked on fluoroscopy as well. The instruments are then removed and the position of the access chisel and working cannula are confirmed on FOSS view with care taken to get a view down the barrel of the working cannula to ensure that there is medial clear space in the facet joint. Implant is then placed through the working cannula and then impacted into position and checked on fluoroscopy to ensure that it is not anterior to the pedicle and as close to the posterior margin of the facet joint as possible. Interfixated screw is then placed through a posterior portion of the facet cage, and the hand is brought down once the screw is engaged until it snaps off, and then bone graft is placed behind the screw and checked on fluoroscopy for adequate placement of the screw as well as cage.